In this session, we will go over several multinodular goiter thyroidectomy specimens. We will go over gross features and take you through grossing for both benign and possibly malignant samples. Sit back and let's get started.
Okay, so what type of specimen do you think this is? Feel free to answer as you wish. These questions are completely anonymous, so feel free just to select the answer that best reflects what we're seeing here on the screen. Okay, fantastic. So thank you very much. And it looks like the majority of respondents selected the most correct answer, that this is indeed a thyroid gland. So let's take a look at some of the other options here. So if we were thinking that this was a tongue, what might we be expecting to see, and how might this be different? In the chat, what types of features would we be looking for if this was a resection of the tongue? And also if we can put in the chat what the name of a tongue resection is called. Yeah, so definitely we'd see some muscle, and a resection of the tongue is called a glossectomy. I think in terms of the shape, you would probably see something similar in shape, and I think that's why this might be a bit of a tricky specimen to land on in terms of what type of resection. One of the more important features is that you would typically expect to see some mucosa on the surface of the tongue, whether it be on the side or on the dorsal-ventral aspects of the tongue, depending on the type of resection that's been excised. So I'm glad nobody selected uterus. This would be an unusual configuration for uterus. We're missing a lot of the different landmarks that we would typically expect. We're missing the body of the uterus, the uterine cervix, the fallopian tubes and ovaries. So for this to be a bladder, this would be unusual because it would be so small. But we can tell that this is a solid organ as opposed to something that has a lumen. So we can exclude the bladder. And then going to a soft tissue resection based on what we can see on the screen, this could easily qualify as a soft tissue resection. But perhaps what are some of the features we might be missing to exclude this from being a soft tissue resection? Yeah, okay, so sometimes we can get some skin on it. Generally speaking, we'd probably see some muscle, plus or minus some fat, and then plus or minus some fascia as well. What we're going to talk about today are indeed some thyroids, and we're going to look at the different types of thyroid resections. Just take a step back and think about some anatomy. The thyroid gland can be found within your neck, and it sits just below the larynx on the tracheal surface. Most thyroid glands, if you have the total thyroid, is a butterfly-shaped organ, and it has either this H configuration or like a U-shaped configuration, depending on the nature of the resection and the nature of the thyroid gland itself. And so what we can see here is we really only have one side of the thyroid. This would have a bridging isthmus coming across, and then a second lobe that would come around on the other side. And I'll see a nice example of it in a little bit. So yeah, there's two lobes, the right and the left, connected via the isthmus, which sits transversely across the trachea. The superior aspect of each lobe comes to a slight point and extends more superior from the isthmus. If you can imagine, the isthmus would be right down here. You would have the superior part of each of the right and the left lobe extending a little bit more superiorly. The superior tip extends up to the level of the thyroid cartilage on the larynx, and then inferiorly sits around the cricoid cartilage. Occasionally, sitting on top of the isthmus, you can have a pyramidal lobe, and it's a normal kind of anatomic variant, and it's this triangular shaped accessory lobe of the thyroid. Okay, so maybe a question related to the pyramidal lobe. What anatomic structure is that pyramidal lobe related to? Anybody know?
The pyramidal lobe.
Yeah, excellent. It's the thyroglossal duct. Does anybody know what percent of the population has this pyramidal lobe? Yeah, anywhere between 10 to 30, depending on where you're reading. So you do see it occasionally. From an embryology standpoint, the thyroid gland is actually the first endocrine organ to start developing. And that's typically happens around the 4-week mark. And then it starts actually functioning around a 4-month mark. What type of thyroid resection is this? And so what you can see on the poll here are a number of different thyroid resection specimen types. Based on what you can see, which one do you think this is? Okay, excellent. A total thyroidectomy would require that both the right and left lobes of the thyroid, including the isthmus, be resected altogether. Sometimes they can be resected as separate specimens, but generally they come together. A subtotal thyroidectomy, can anybody share with us what that typically would include in terms of the extent of thyroid being resected? Yeah, okay, so it would include one lobe with the isthmus. From a surgical standpoint, it would include some of the contralateral lobe as well. If this were the right side, it would be the right lobe, isthmus, and a little bit of the left as well to be considered a subtotal from a surgical standpoint. Hemithyroidectomy would be what we see here, okay, and this would be a resection of one lobe plus part of the isthmus, which is probably just tucked into the side here. A partial lobectomy would infer that we're resecting a part of one lobe rather than the entire lobe. And an enucleation would be resecting just a thyroid nodule, depending on the nature of the pathology, and would just basically pop out the tumor. Okay, so we're here looking at a hemithyroid. Okay, so in the chat, can we get some ideas for why a patient might have a thyroidectomy performed? What are some reasons as to surgical intervention and having thyroids removed? There's a number of different reasons. The approach talking about goiter and then neoplasms and then benign and malignant. PTC.
Yeah. How about some more benign stuff? I think we have Graves and MNG, multinodular goiter. Any other benign-ish or maybe neoplastic benign-ish conditions that might warrant? Good. Hashi, just autoimmune condition. Yeah, adenomas for sure.
Absolutely.
Way more common, right? And then don't forget infectious causes too. So what's the really painful one that can give you a thyroid toxicosis? If anyone, yes, the core vein. Thank you. Hashimoto typically is not painful. It's just large, but the core vein is the one that's really painful, and it's usually an infectious cause.
Okay,
good. Those are really good differentials.
Okay, let's go to the specimen now. I'm just going to show you some of the cut surfaces, and as I do, let's get some descriptors on what we're seeing. We're going to start at the superior pole and work our way all the way down. What are some descriptors of what we're seeing here? Good, we've got cystic, some fleshy, glistening colloid material. Cystic spaces, yes, absolutely. Multinodular, yep.
Yes, good.
You can appreciate there's a number of different nodules happening throughout the lobe here. Yes, query encapsulated, yeah, so maybe not, hard to say. We'll do a quick tour again. Yeah, there's some areas that look a little bit more kind of papillary, although I think it's just probably the nature of some of these nodules here.
How about some pertinent negatives, folks? What are you not seeing? Might be worthwhile to mention. Hemorrhage, overt necrosis, those are good. Calcifications. Yeah. Of course, you're going to point it out. So there is calcifications, my bad.
There is definitely some calcification here.
So if you can just hold here, just if you can tell people normal, just orient people what normal thyroid looks like and that there is actually normal in here.
There's not a ton of normal here to look at.
I thought the more kind of beefy looking on the side here.
So I think there's actually another nodule there, and I think the intervening stuff right down, so if I can get my finger straight up. There we go. Then,
okay.
Right here is some more normally looking thyroid parenchyma, but there isn't a ton of actually normal thyroid parenchyma here, and I think that was an important observation when we're looking at and talking about the growth is that there's actually not a lot of residual thyroid, and it's definitely taken up by this multinodular lesions. Okay. So based on what we're looking at, what do folks favor in terms of what these nodules are? Okay. Follicular nodular disease, MNG, so multinodular goiter, yeah. Anything else? Between the two that have been presented, what do folks favor more over the other? There we go. So this is looking at the cut surfaces, and given how multinodular it is, I think some keen eyes notice some of these more gelatinous and more cotton colloid rich areas. This is indeed an example of multinodular goiter. The key features are the fact that there's some calcium here and that there are focal areas that are more calcified, but you can see the heterogeneity from nodule to nodule. And you can see how different it is up here. It's got a little bit of a more solid appearance, but the specimen does have a more gelatinous appearance. As you move further inferiorly, you've got some of these more cystic spaces, and again, some more gelatinous areas that would lead this to being more in this goiter type of scenario. Okay, let's go to our second specimen, and we'll launch our next poll question. Given what we've chatted about briefly already, what type of thyroidectomy do you think this is? So this is really interesting. We've got answers for a subtotal thyroidectomy and another selection for hemithyroidectomy. I think a lot of the community probably uses both of these words interchangeably. From a surgical standpoint, a subtotal thyroidectomy is one lobe plus the isthmus and then a little bit of the contralateral side. And a hemithyroid, again, from a surgical standpoint, is one lobe plus the isthmus. I think we've got here a hemithyroidectomy, but I do recognize that I think we probably use both of these words rather interchangeably when it comes to just our practice kind of day to day talking about these specimens. Okay. This is a hemithyroidectomy because we have one lobe plus the isthmus. Let's go through the cut surfaces of this lesion now. What are some descriptors of this nodule?
Keep in mind those descriptors that were used prior. If you're new, hopefully this exercise will help you build your vocabulary in terms of how these things are described.
Okay, so we've got some multinodular going on. It is very glistening, and I think part of it is just the formalin in the water that's on here. It takes some of the shine off.
Yeah, some of these words here.
Partially lobulated septae. There's some septae kind of floating through the middle here. You can see these white streaky fibrous bands.
Agree, homogeneous and solid. So there's anything it's encapsulated.
Yeah, so I think this is tricky. Sometimes it's actually really difficult to grossly appreciate encapsulation of nodules. If I had to, I might suggest that this nodule here might have a capsule, but it's hard to tell sometimes. It's rather difficult. Okay. So yeah, one of the key descriptors that I would use for this, and again, I think maybe it's just the color coming through the camera, is I'd probably use the word fleshy for this one as well, and more on this slice. And I recognize the camera's probably making this a little bit more darker than it is, but this is definitely very fleshy. Okay. And what are some thoughts then on the differential for this lesion in terms of what this lesion might be? So we've got a follicular neoplasm. Yeah, great idea. Okay, multinodular goiter, possibly. Any other considerations?
Good.
Excellent. Adenoma, a non-oncocytic neoplasm.
Any votes for cancer?
Anybody voting for cancer?
I find that's interesting that people are gravitating towards more benign kind of thing, which I would agree with.
Absolutely. Yeah, so I think given the cut surfaces and how well circumscribed this is, considering this to be an adenoma or some type of follicular neoplasm is within higher order in terms of our differential. We would have to look at the capsule to decide what this is and whether this turns into something more malignant than perhaps benign. And I think that's the important part here in terms of sectioning for this particular specimen. We want to ensure we evaluate the entire periphery of the lesion. And for this, it'll be easy because it'll fit into a cassette without too much effort. You'd be able to evaluate that histologically to then decide which way it goes. Now, if this were a papillary carcinoma, that's not to say that they can't look like this, because I think the papillary carcinomas are really interesting in that they do have a number of different gross appearances. So when it comes to papillary thyroid carcinomas, and maybe consider the ones that you've come across the bench, or maybe you've seen some in textbooks, what do they typically look like, and what type of descriptors could you use to describe these tumors? You can see quite a spread in terms of the descriptors that you would apply to describing some of these papillary lesions. Friable is a really great one. For those of you that have seen it, you can often see parts of the tumor crumble away from the cut surface. Papillary carcinomas can also look stellate and ill-defined, like you would normally see, or when you would normally think about what cancers might look like, being irregular with poorly defined borders. They can definitely be cystic, either in part or in whole. Gelatinous is another great descriptor for some of these papillary lesions, and occasionally you can see areas of calcification throughout. Myxoid is one that we don't generally see in terms of describing papillary lesions. Myxoid would be a little bit more gelatinous, but it would have a tacky, kind of gooey, sticky, mucoidy texture to it, and we don't generally see that with these papillary lesions. The point here is that papillary carcinoma can take on a number of different gross appearances, and it's important to then describe the different elements that you're seeing when it comes across your bench. Okay. So I think when it comes to this specimen, I think with some of the differential that we've been talking about in the chat, favoring something from an adenoma to something follicular is definitely higher up on the list. Okay.
We'll get back to how we gross these things after. We'll do them all together with our third and final specimen.
So let's take our third and final specimen now, and then we'll do that quick question again on what type of thyroid you think this one is. Let's get that into focus. There we go. Fantastic. This is a nice example of a total thyroid. We have one lobe here on the left side of your screen. We've got the contralateral lobe. So this is the left lobe on the right side of your screen, and then the isthmus coming across here. Okay, so we're looking at the anterior surface of the thyroid. If you look at it from the back side, we can see this U-shaped or H-shaped butterfly kind of configuration of the thyroid. What are some descriptors based on the overall specimen before we go into the cut surfaces? Yeah, it's asymmetrical. This is the right lobe here, and you can see how much bigger it is by comparison to the left lobe. Okay, so taking a look at the cut surfaces, and so here's a nice example of what normal-looking thyroid tissue should look like. Okay, it's nice dark brown, beefy red, exactly. Depending on just how long it's been fixing. Obviously, if it's been fixing for a shorter period of time, you might expect it to be a little bit more pink, a little bit more red. But this has been fixing for a couple of days now. And so we've got this nice dark brown appearance to the lobe. Okay. So you can see on the left side, there's not a whole lot going on in terms of the cut surfaces until we get to here.
That's near the isthmus?
This is near the isthmus towards the
Yeah.
inferior pole.
Yeah.
Here's some descriptors of this lesion now.
That's very nice.
Yeah. Multicystic, absolutely. Maybe some necrosis. We can talk about that in a little bit.
So I'm curious, were there contents?
Yeah, so there was definitely contents in this, and it was a bit of a viscous, dark red and brown fluid with some kind of chunky stuff in it, which I think was some of the stuff here. Good, so we've got glistening, we've got solid and cystic, absolutely. Okay, so really great descriptors for this lesion. Thoughts in terms of the differential for this nodule?
What do you think? What could this be?
Okay, maybe papillary.
I'm assuming papillary thyroid CA.
Other thoughts on what this lesion could be? Maybe everybody's also favoring papillary.
Any votes for benign? That's a good one. Cystic degeneration and multinodular goiter.
Good. Okay, so what's really interesting is this particular case was submitted to us as multinodular goiter. And I think when I took the specimen out and was starting to prep it, I thought, okay, sure, fine. But as I started cutting across it, these more solid areas really caught my eye. And you can see how solid it is. It's got this very fleshy appearance, which kind of made me a little bit worried in terms of what this could be. And then again, if you look through here.
What are those? In the chat.
Yeah. So this is a nice example of how we would use the word papillary to describe some of the features of the gross specimen, right? And papillary really refers to these things sticking out off of the surface, that textured part of the lesion sticking up into. So a nice example of using the word papillary to describe what you're seeing. Given what that looked like, I thought, oh, this is really strange. It's very interesting. It got me a little bit worried that this is probably a little bit more than a goiter. This stuff, the solid component here is actually quite solid. This is a little bit friable here, like the papillary part, okay?
But then you also say that the content had some of the
Yeah, that's right.
lesions that came off from there.
Exactly.
I appreciate that.
Yeah, and I agree. It does have a very unusual appearance in terms of what we're seeing here. And in terms of wording, you can definitely use papillary projections. You can use papillary excrescences, and that's a fancy word of just saying basically projections. Both ways are adequate to describe what we're seeing here. Okay. So we're not sure what this is, but I think to a point earlier in the chat, what are the important features in terms of sampling for this lesion? Yeah, exactly. Looking at the periphery of the nodule here in its entirety histologically to see any evidence that this is something more than just a goiter. When it comes to receiving these specimens, so the first thing you want to do is weigh the specimen. All of our thyroid glands are weighed. You want to weigh whole organs. You also want to ink the cut surfaces, or sorry, not ink the external surfaces before you start cutting. From there, double check the clinical history and make sure you recognize why the specimen was resected to correlate your findings. And also just always ensure the orientation is correct as it's recorded on the requisition. We find often with the thyroid glands is always a flip between right and left, depending on if you're looking at it from the patient standpoint or if somebody in the OR is actually putting the stitch on the left side as opposed to the patient's left side and the left lobe of the thyroid. And then do some cuts into the specimen to allow fixation. I'm just curious in terms of what the community is doing when it comes to prepping. How do you prep your thyroid glands in terms of the planes of your cuts? Do you cut transverse sections, what we have here? Do you do sagittal sections going front to back? Do you bivalve and butterfly each lobe? If there's another way that you approach your sections, let us know.
We ask these questions because there's no right or wrong way. The importance here is to know what your departmental protocol is.
Good. I think it's nice to see some variation in terms of how thyroids are handled. It looks like the majority of the community is doing transverse sections, similar to what we have in our specimen. Sagittal sections is interesting. I think that's neat just to see that approach. And I've seen the butterfly and bivalve method before as well. When it comes to grossing now, want to record the weight, want to record the size of each of the lobes, the right, the left, and the isthmus as well. Recording that in 3 dimensions. And then as you go into your description, looking at your pathologies, we've got one dominant mass here occupying the majority of the right lobe. We'll talk about what that looks like, its contents, and using a lot of the great descriptors we've offered in the chat. We'll also include some detail about the other nodule in the inferior pole of the left lobe, commenting on its cut surface and some of the background thyroid parenchyma as well. On any thyroid gland, you always want to be mindful and look for parathyroid glands that are sitting on the back of the thyroid. Generally speaking, we don't often see them, but you do want to be aware that they could exist there as well. From a section standpoint, we talked a little bit about these very fleshy follicular type nodules. Sampling the periphery and the capsule of these nodules is vitally important. If this was a papillary lesion, we'd probably just take representative, but given how fleshy it looks, follicular type lesions are higher up on the list. And so it would be important to then sample the periphery of this nodule in its entirety from top to bottom. When it comes to sampling the poles of each of the thyroid lobes, there's definitely some variation in the community in terms of how you sample that. We'll do our last poll question here. For the gross, how do you sample your superior and inferior tips? Do you do them perpendicular? Do you do them transversely? Or do you have another approach? So you can see there's a bit of variation in the practice in the community. There's no right or wrong way. A lot of it just depends on what you're trying to show histologically, and changing the plane is sometimes helpful to see some of that anatomic relationship.
And so essentially that's pretty much the same type of sampling or grossing protocol for the other 2 specimens. Always use the 1 per centimeter rule. But again, this one, especially for follicular lesions, you have to be a bit more deliberate in terms of sampling more of the capsule, because that's often the challenge with these cases. So I understand it's better to always oversample than not in these types of scenarios. That said, we'll just do a little bit of summary. I just want to start off with this table. One of the important things about grossing, especially for thyroids, is looking at previous biopsy, specifically any FNA that was done. There are specific diagnostic criteria associated with an FNA and an associated risk of malignancy. So it's important to know those ideas because it gives you some guidance in terms of how well you're going to sample this lesion that you might see, as well as there's been a recent change in the clinical management for these things, with molecular testing having a more prominent role now in terms of how you manage these diagnostic or cytological diagnostic criteria. So highly recommend that if you haven't done so, familiarize yourself about these diagnostic criteria and their associated risks. So this is our first specimen showing this multinodular process encompassing the entirety of the lobe. Again, here, just the various and the heterogeneous cut surface from solid to a bit more cystic. And this is typically the type of picture that you want to see for multinodular goiter. This second specimen has almost an entire lobe involvement, both from an inferior on this, sorry, what did we call it? A hemi?
I think we call this a hemi, yeah.
Yeah. But the difference here is that this more homogeneous kind of look. If it wasn't clear, the kind of overarching theme for today's session was follicular lesions. And you can have different types of cut surfaces. This one lends more towards what people were talking about, that this is probably more neoplastic on the benign side of things, given the homogeneity of the cut surfaces that we're seeing. And then this asymmetrical third sample here on the posterior aspect, you can see the concavity here, where it would sit in front of the thyroid cartilage, showing this asymmetrically large one side. On the cut surfaces here, just this variegated, heterogeneous kind of look, this papillary type of excrescences that you can see on some surfaces, which is quite concerning. Sorry, this is a better picture. And again, just the multicystic nature with all these little projections, which on this picture actually looks like it's probably clot. But nonetheless, again, you want to look at your history, and on grossing, certainly sample this much more focusing on the capsule, if you can go around and capture that. And the reason that's important for follicular lesions is that capsular invasion is a key determinant on whether you're going to call this a carcinoma or not. And there's different histologic criteria for what amounts to capsular invasion. So it's all outlined in the College of American Pathologists protocol. So it's important to document this, and you can only fully document this by sampling the capsule in its entirety. That's why we keep drilling on this idea that you have to sample the capsule as much as you can. And then just wanted to go over this entity called the NIFTP. In any case, there's major and minor inclusion criteria for what constitutes a NIFTP. So I would highly recommend that you familiarize yourself for this, because it has both gross as well as histologic features associated with the inclusion criteria. There's also exclusion criteria for a NIFTP. These are very important to know because you can see these grossly if needed. While we didn't really talk about PTC, I want to end up with a reminder of the PT staging for papillary thyroid carcinoma, paying attention to the size restriction and the size limits, as well as any extrathyroidal extension, which determines your higher stage disease categories. For grossing, as we mentioned before, clinical history, specifically any previous FNA or diagnosis based on cytology, is very important. Always orient yourself. Make sure you insist on a properly oriented specimen when it arrives, meaning what they say on the requisition matches with what you have anatomically. Look up someone from the surgical team if things don't align properly. Make sure you ink the external surface. You do your measurements, both weight and size in 3 dimensions. Organize your approach of descriptors by lobes. Describe the cut surfaces. If you have a follicular lesion, pay extra attention to the capsule and look for any gross invasion. And then, when you sample the lesion, try as much as you can to sample it with the capsule nearby. Normal parenchyma if it's available. Lymph nodes if applicable. And I should also add parathyroids if applicable. Feedback always welcome. And thank you for joining us once again.